Happy Saturday. Today on Diabetic Profiles, we're going to dive into blood. So imagine placing two drops of blood under the microscope, one from a healthy individual and the other from someone who has poorly controlled diabetes. At first glance, they look very similar: red blood cells, white blood cells, platelet, plasma. But then when we zoom in at the microscopic level, the diabetes actually transforms the blood in an entirely different biological environment. The red blood cells are stiffer, the white blood cells become dysfunctional, the platelets become stickier, and the inflammatory molecules flood the circulation. And every one of those changes contributes to diabetic foot ulcers, infection, poor healing, amputations, unfortunately, heart attack, stroke, kidney disease. So today in diabetic foot files, we're going to follow a single drop of blood from a diabetic patient underneath the microscope. And before anything, you already know I love to go into the history of things. So, what's the history of blood? So, it was always there, right? Everything has blood, I think. But on a side note, I just remember like when I first saw the blood of a crab and it's like bluish jelly like, right? But side note. But before we can understand diabetic blood, we have to understand how scientists learned to see blood. So the first person to observe blood cells was Antoine van Leeuwenhoek, okay? And in the late 1600s, he built microscopes capable of magnifying objects 100 times more, right? And when he examined blood, he described tiny red structures swimming through the plasma, and that's pretty much him discovering red blood cells. And for the first time in human history, people could see the building blocks of our circulation. And so today in modern microscopy allows us to see the changes in diabetic blood at a cellular and molecular level now. I remember my first microscope. Yay. So let's talk about a healthy red blood cell is a marvel of engineering. Healthy red blood cells, they're round, they're flexible, they are biconcave and approximately 7 to 8 microns wide. So think of them as these tiny rubber rafts. Their flexibility allows them to squeeze through the capillaries smaller than their own diameter. Some capillaries are only literally 3 microns wide, yet healthy blood cells, they can pass through this effortlessly. This flexibility is quite critical to delivering the oxygen through the tissue. So what happens when your blood sugar is high? What does it do to the blood cells, the red blood cells? So when we introduce chronic hyperglycemia, the glucose begins attaching itself to the proteins. And this process is called advanced glycation end products. We've discussed that before. And these advanced glycation end products damage the red blood cells. So under the microscope, you start seeing reduced flexibility. The membranes stiffen, the cells become less elastic. And instead of a flexible raft, it behaves more like a rigid hockey puck. So imagine from healthy, flexible raft, right? Like on like the the lake, right? River rafting, but now it's a rigid hockey puck. So what would that result in? Consequences of that would be slower blood flow, reduced oxygen delivery, capillary blockage, and poor wound healing. And this is one of the reasons why diabetic foot ulcers struggle to heal. The oxygen literally cannot reach the tissue efficiently. So, another thing is rouleau formation, rouleau formation. So the word rouleau comes from the French word means rolls and stacks. So in normal red blood cells repel one another because their surfaces carry negative electrical charge called zeta potential. Okay, we'll get deep into that some other day. But zeta potential, and this negative charge keeps the cells separated and flowing smoothly through the blood vessels. But when rouleau develops, the red blood cells, and let me just spell it for you so you can understand. Rouleau, Rouleaux. So rouleau formation. So when the rouleau develops, the red blood cells lose some of its repulsive force and they begin stacking and sticking together in these long stacks that resemble like poker chips piled on a column or a roll of quarters. Okay, so underneath the microscope, it's actually one of the most recognizable hematological findings. So how does that happen? So the key mechanism is the increase of certain proteins in the plasma. So normally red blood cells, like I said, has the negative charges, zeta potential, and the cells repel each other and the blood can flow efficiently. When plasma proteins rise, especially like the fiber immunoglobulins in the antibodies, the acute phase proteins. These proteins coat the red blood cells and reduces the zeta potential, that negative charge potential that's on the red blood cells. And the red blood cells can now drift closer together and stack. And think of this like imagine several magnets with the same pole facing each other. They naturally repel. Now imagine putting a thick blanket between them, the repulsive forces weakens and now they stick together. And that's essentially what happens when there's excessive plasma protein. So Rouleaux formation is not autoagglutration. Okay, so that's one of the most important distinctions in hematology. Rouleau formation, the cells form an orderly stack. They look like coin columns. They are caused by increased plasma proteins and usually reversible when the blood is diluted with saline. Listen to that. That's good to know. So autoagglutination, agglutination, forgive me, autoagglutination, that's the right word. Cells form irregular clumps. They look chaotic. They usually are caused by antibodies binding to the red blood cells, and they do not disperse when they're saline. So there's a distinctive difference between rouleau formation, which is stacking, and autoagglutination, which is clumping. So under the microscope, they appear similar at a low magnification level, but closer inspection reveals the difference. So why am I talking about Rouleau formation in the first place, right? It is not a disease itself. Rouleau formation is not a disease. It's a microscopic clue, and it tells us that something in the plasma environment has changed, like smoking indicating a fire, right? Rouleau points to the condition that there's an underlying condition. So, what conditions are associated with Rouleau formation? Inflammatory disease. Any condition causing significant inflammation can increase fibrinogen and acute phase reactants. So, things like rheumatoid arthritis, systemic lupus erythematosus, chronic infection, severe tissue injury, multiple myeloma, which is that's one of the classic associations with rouleau formations. In multiple myeloma, the plasma cells produce enormous amounts of monoclonal antibodies. The plasma protein's concentration rises dramatically, and rouleau formation becomes very prominent. So many textbooks, pathology textbooks, use multiple myeloma as a classic example of rouleau formation, but it actually happens also in chronic infections like tuberculosis or what we see often chronic osteomyelitis or endocarditis. But Rouleau's formation is actually quite relevant to us in wound care because it happens in diabetes and chronic wounds, okay? So in patients with diabetic foot ulcers, chronic inflammation, osteomyelitis, severe infections, acute phase proteins and fibrogen actually rises, and this increases the red blood cell aggre- aggregation and promotes rouleau formation. And researchers have linked increase of these red blood agree. Let's just they've caused this increased aggregation. Well, forgive me. I don't know why I get tongue-tied when I say certain things sometimes. But yeah, the aggregation of the red blood cells to impaired microcirculation and the worsened tissue oxygen delivery in diabetic wounds. So, what does rouleau formation do to the blood flow? So, you can imagine it makes the blood flow less efficient, right? So that's why it's particularly important because rouleau formation, the consequence will be increased blood viscosity. I remember doing a debridement on a patient and their blood was so viscous. Like, the viscosity was so thick, it was like molasses blood. It was very interesting just watching it drip down, right? The thick it was really thick blood. I was like, "Oh, wow, this is interesting." But that's pretty much because of the Rouleaux formation and the hyperglycemia, right? Because it was very sticky, increased blood viscosity, reduced microvascular flow, impaired oxygen delivery, and sluggish capillary circulation. But literally, if somebody has very high blood sugar, their blood does look like molasses, like thick molasses. If you're doing a debridement and it's a significant amount of blood, it literally adheres itself. Like you literally can use your hand to just pull the blood off because it literally sticks together so significantly. So this is particularly important for us, right? Because diabetic patients, peripheral arterial disease, chronic wounds, critical limb ischemia, these tiny capillaries depend on the flexibility of the individual red blood cells squeezing through one at a time, not these large stacks that don't move nearly as efficiently. So, another thing that rouleau formation causes is it increases your erythrocyte sedimentation rate, your ESR rises. So, ESR, erythrocyte sedimentation rate, normally individual red blood cells settle slowly. But in rouleau formation, the stacks become heavier and they sink faster, right? Because they're heavier through the test tube. So that would result in a higher ESR, erythrocyte sedimentation rate. And this is why elevated ESR is often seen in multiple myeloma or osteomyelitis, chronic infections, autoimmune diseases, okay? So, our connection to wound care, like I said, for us wound care specialists, Rouleau can be viewed as a warning sign that the patient's blood environment is changing. So, a patient with a chronic diabetic foot ulcer, a deep infection, osteomyelitis, systemic inflammation may demonstrate increased red blood cell aggregation and rouleau formation. And the microscopic level is revealing something that's happening systemically in the patient's blood. The inflammation is altering the blood long before the clinical deterioration becomes very obvious. So, in rouleau, why does rouleau formation actually really happen in diabetes? So, rouleau formation is not caused by diabetes itself. Okay, in the same direct way that is caused by multiple myeloma. Diabetes actually, yet again, creates a blood environment that causes the red blood cells to aggregate and stack together. So think of diabetes as creating yet again another perfect condition storm, and it creates the perfect conditions for rouleau formation. So one of the hallmarks of diabetes is what does diabetic foot ulcers get stuck in? An inflammatory state. Diabetes has a persistent low-grade inflammation, persistent low-grade inflammation. Keep that always in mind, okay? So over time, diabetic patients have this elevated fibrinogen, elevated CRP, elevated inflammatory cytokines, acute phase reactants, and these proteins circulate into the blood plasma and reduce the normal repulsive forces, right? The zeta potential forces between the red blood cells. And as the fibrinogen rises, the red blood cells can stack more easily and alter deformation and form rouleau. Now, we already talked a little bit about end stage glycation paradox, but patients who definitely need to understand that when we say blood sugar, literally it's blood sugar. Like your blood is turning into molasses. So imagine that nice, healthy blood with dilution flowing, right? And thick molasses blood. It's really hard. That's why we keep on asking you to manage your blood sugar, okay? It's not just blood sugar, it's how much the hyperglycemia changes pretty much the whole dynamic of your body system. So glucose doesn't float around harmlessly. It attaches to proteins throughout the body through the process of glycation. So the red blood cell membranes become glycated as well. So this changes your membrane flexibility, the surface charge, like we said, the zeta potential, it changes that, and the cell to cell interactions. So the alteration to the red blood cells become more likely to aggregate. Imagine taking a smooth billiard balls and then making their surface slightly sticky and interacting with them differently. And like we said, they increase plasma proteins. Many diabetics experience that. They have elevated plasma proteins due to the chronic inflammation, due to infection, due to kidney disease, due to diabetic foot ulcers, due to osteomyelitis. And these proteins act like molecular bridges between the red blood cells and causes a higher fibrinogen level, which causes a greater tendency towards the rouleau formation. And oxidative stress diabetes produces large amounts of reactive oxygen species. We did a whole episode on that. Oxidative stress damages the red blood cells, the endothelial cells, and the plasma proteins. Damaged red blood cells become less deformable and more likely to aggregate. And diabetic foot infections make it worse, okay? So when diabetes develops, cellulitis, if they develop abscesses, osteomyelitis, or infected diabetic foot ulcers, the inflammatory proteins, of course, dramatically increase. And the blood becomes what? More viscous. And the red blood cells become more, there's more aggregation increasing. Okay? And that is why in our severe diabetic foot infections, you see elevated ESR, CRP, and fibrinogen, all which promotes rouleau formation. And then diabetic kidney disease, okay? So diabetic kidney disease can contribute further because the kidney dysfunction leads to increased inflammatory mediators, altered plasma protein concentrates, chronic systemic inflammation, which still also enhance the red blood cell aggregation. So what does that mean for our feet? Okay? The foot depends on these tiny capillaries to deliver oxygen. Normal person, like we said, the red blood cells can squeeze through one at a time. But with the rouleau formation, the blood, like I said, becomes viscous. Think of blood molasses. Flows slowly, oxygen delivery decreases, and tissue hypoxia worsens. And this doesn't directly cause ulcers, but can contribute to the impaired microcirculation that already persists in diabetes. Okay? So technically, like we said, the patient has sticky blood, okay? And then you have to think about our white blood cells, okay? Under the microscope, neutrophils show reduced migration in diabetes, okay? Reduced bacterial killing, reduced phagocytosis. So our soldiers are arriving late to the infection and fighting poorly, okay? Because I think they're drunk on sugar. Let's say that, okay? And that's why diabetic foot infections become so severe, okay? And we talked about our platelets. And now let's talk a little bit about our endothelial lining, okay? The endothelium. Our blood vessel lining, the endothelium. The endothelium is normally smooth, right? Like fresh wax glass, that smooth, right? Nice to touch. And in diabetes, the oxidative stress rises, the inflammation, and the nitric oxide decreases. So, what happens to the endothelial vessel lining? It becomes damaged. The blood cells become interacting abnormally with the vessel wall, and they that helps the beginning of diabetic vascular disease, unfortunately. So our diabetic blood delivers less efficiently. That's pretty much the understanding of it. The red blood cells are stiff, the white blood cells are dysfunctional, the platelets are abnormal, and the vessels are already damaged. So that's why we have to understand why this is so important, okay? Because that's why we are referring you to vascular, okay? Vascular, okay? The blood becomes trapped in inflammation and healing is very dramatically slower. So that's another thing patient needs to understand. They might be like, why is it taking long? It's because of what's going on. And the better your blood sugar is controlled, the more likely we can help speed up the healing. Also, when it comes to nutrition and vascular assessment and stabilization, these are things that help you heal faster. But I want patients to understand that this is not just something like we put a dressing on and it heals the wound. We have to do the inside as well, and you have to do your part, okay? And your part is definitely making sure you follow up with your doctors, go to the right referrals, and controlling your glucose. Glucose control is a huge thing. That's why we always ask you, what is your hemoglobin A1C, okay? Can your blood improve? Actually, yes. Okay. Research has shown improvement occurs with glycemic control. That's why we keep on telling you exercise. It is very good to exercise. weight loss, smoking cessation, you already know not to smoke, infection treatment. So red blood cell flexibility can improve. So that's a really good sign, okay? If we can change our glucose control and glycemic control and get it better to another level, a better level, we can help the red blood cell flexibility a little bit, okay? Inflammation decreases, the platelet activation can normalize, the microcirculation can recover, okay? Your body, I want patients to understand, is your body is constantly attempting to repair itself. That's why it's constantly in inflammation. It's constantly trying to help. And us as wound care specialists, we are removing the blockages, okay? Vascular surgeons, they are helping the blood flow. But us as wound care specialists and podiatrists, we're trying to remove the blockages, whether it's pressure, whether it's necrotic tissue and debridement and bacteria with antibiotics, things like that. We're moving it, but your body is the thing that actually heals itself. Your body is the thing that it actually is healing, okay? Your body has the ability. It just needs to be under the right conditions. And that's the one I want patients to understand. You're the superhero in all of this. You're the one who's healing, okay? So when you look at diabetic blood underneath the microscope, you don't just see blood. You actually see the story of diabetes itself. You see oxygen is struggling to reach the tissue. You see the immune cells are trying to fight, but not that well, right? This isn't like Fight Club. It's like they opt out of Fight Club with Brad Pitt, right? And you see the platelets preparing to clot, you see inflammation, you see glycation, you see oxidative stress, you see vascular injury all happening simultaneously. And perhaps you'll see why the foot ulcer occurs. The ulcer is simply not a hole in the skin. It's a visible consequence of millions of microscopic events occurring inside a single drop of blood. Okay. So every diabetic foot ulcer begins with a story, okay? Way before the skin breakdown. That's why when there's a diabetic foot ulcer, like I always say, it's like the white flag surrendering, right? They're like saying some I'm surrendering, okay? Because you have to think about it, how far your foot is from your heart, okay? So if it could get that bad down there, imagine how bad it is up there. So we have to treat the patient as a whole, make sure they follow up with cardiovascular, make sure they follow up with the vascular, make sure they get the A duplex, make sure they follow up even with the endocrinologist, the internal medicine, kidney doctors, everybody. It's a whole team of us, the nutritionist. You have to remember, we have to treat the patient as a whole. Without that, the ulcer will not heal properly. We have to treat the patient as a whole. It's not just one thing. It's not. Diabetic ulcers are never just caused by one thing, okay? So I hope everybody remembers that. The clues are already through the blood flow, hidden in a single drop of blood, waiting for us to understand the story. Like I said, every diabetic foot ulcer is a story, and this is Diabetic Foot Files. I'm Dr. G. And this is where we follow science all the way down to the microscopic level so we can help save limbs, preserve mobility, and change lives. And I'm Dr. G, and take care of your feet because they take care of you. And I hope everybody has an amazing weekend. I'm going to. Yay.